Hi everybody, welcome to another episode of the 50 Shades of Pain show. I'm here with a good friend of mine, Dr. Suleiman, who's from Nigeria. We met, how long ago did we meet?
10 years ago.
Oh my goodness, 10 years ago we met at a conference, and we've been talking ever since. And I've been wanting him to come visit, he's been wanting to come visit. But it's taken about 10 years for that to actually happen. He's going to be shadowing with me for the next couple of weeks. And during that time, it's interesting. It's always interesting to hear about how people do things differently, the different contexts. And I do that with colleagues in the US quite a bit. I'll go visit them or they'll come visit me. And we just learn from each other's techniques. But this is a special one because not only are we dealing with regional differences, we're also dealing with cultural differences and population differences. So it's interesting for me to hear how other people or the countries deal with pain and what are the more common things that they see just based off of what their culture and their environment is like versus what our culture and what our environment is like. And Dr. Suleiman already made one observation, which you said that Americans tend to be heavier than Nigerians, which definitely does have an impact on the evolution of back pain. Now, as I understand, you're an anesthesiologist, correct? Yeah. And then you've done a lot of work in the area of pain management. And currently in Nigeria, you're practicing anesthesia, but you're also treating patients with mostly back pain. Is that correct?
Absolutely.
And so, tell me a little bit about the patients that you tend to see in Nigeria. What are the conditions or what are the problems that you see more regularly?
Okay, well, thank you very much, Danish. You see, in Nigeria, we have patients with back pain arising from, disc problem.
Yeah.
One of the observations we notice is because of the physical, nature of the work they do in Nigeria. So it involves a lot of, physical activity, a lot of bending and twisting. So that predisposes them to chronic back pain, especially as they, grow older. So before now, everybody treats, pain in Nigeria, including the people that open drugstores. So, and essentially what they do is they give medications, analgesics, paracetamol, and non-steroidal anti-inflammatory medications. So most of them do come down with, gastritis as a result of the
overuse of
the non-steroidal anti-inflammatory drugs. That put off a lot of people, and they tend to have issues with compliance. So that leads to a kind of a vicious circle, and it creates a situation whereby they become incapacitated. Now, with the introduction of the interventions, I have a lot of patronages from different parts of Nigeria.
So you see people from not just your city, but all over Nigeria.
All over Nigeria.
Wow.
In fact, at times I will be invited to go and see patients in other centers.
Wow.
Yeah.
I imagine your skill set is not common.
Oh, absolutely. It's not common.
So most patients, the mainstay of their treatment is pain medication.
Pain medication.
And when we're talking pain medication, not opioids, correct? There's access to opioids is fairly limited.
Very, very limited.
It's been mostly anti-inflammatories and paracetamol, which is the equivalent of our acetaminophen or the branded name Tylenol.
Exactly.
But so patients will stay on that for a while, and then eventually, what happens to them? Do they just give up, or do they have surgery? What eventually happens?
Surgery is even a late stuff in Nigeria. The back surgery is not as common.
Yeah.
And it's not in all regions that they have back surgeries done. The expertise is very, very limited. So when I started the interventions, at least I have to, given the challenges of the equipment, what I try to do is to determine, which procedures, are more appropriate for the peculiarity of each of the patients. So I try to, I discovered that patients benefit most from transforaminal epidural steroid injections or interlaminar, approach too.
And just to translate what that means, so interlaminar, it's easier to just explain this. These bones, so this is the spine obviously, and the bones that are lining along here, and I'll bring it closer so you can see, these bones are called the lamina of the spine. They cover the spinal canal. So the spinal canal is inside of here where the spinal cord runs, and the lamina is this bony part here. And at every level of the spine, you have lamina in there. So when we talk about epidural injections, we're talking about injections that go into this spinal canal, into this spinal space. But as you can see, there are multiple ways that we can get in there. One is in between the lamina, so in between the lamina, and that's called the interlaminar approach. The other way is to go in through the side entrance called the foramen, and that's called the transforaminal approach. And the goal with those injections is to target, so for instance, just looking at it from the other side, if there's a disc that has been damaged through trauma or through, over time, our discs start to break down. And when that happens, they become more prone to just degeneration and breakage. And so one of the treatments that can be done is to put steroids around that to calm the pain down. But generally speaking, the disc can heal itself. It just takes time, and so we have to manage the symptoms until that time can heal. But and I'll come back around to this, but one of the things that I wanted to show you is some of the regenerative techniques that we're doing that I think work even better than steroids do.
That's good.
And we'll talk about those later.
All right.
But so you were saying, for those patients.
Yes, the interlaminar, and the transforaminal epidural steroid injections, and of course the facet, because one of the good things over there is the magnetic resonance imaging. Even though very, very expensive, and it's only maybe few of our patients could afford it. In fact, the cost of MRI is even much more than the cost of treatment.
Wow.
That's the irony. So
an MRI is a magnetic resonance image. It's we all know what an MRI is, but that's what the abbreviation means. It's just a form of imaging, and that's interesting. So to get the MRI is more expensive to get a treatment.
Absolutely. So if I've had to discuss with many patients, they come and say, please, can you just forget about this imaging? I said, well, I'm in a dilemma. So sometimes, because even with the MRI, you still need to do some correlation between the findings and the the examination, and because I've seen cases where the MRI finding is not, it's a dissonance with the clinical evaluation.
I see that very commonly, where the MRI is suggesting one problem, but the examination is suggesting something else. In fact, while you're here, we'll go through a few of those situations in which I find MRI, I think, is over relied upon actually, and it's not as revealing, in my opinion, as people think it is. There are certain situations in which it's helpful. Like for instance, one of the conditions I talk about a lot is spinal stenosis, and I think in those cases MRI is really useful. But for most patients, like the normal, for the average back pain patient, MRI I think is not imperative, not necessary. We can figure things out with other ways.
Exactly. So, but to most of those patients, what I do now, if the patients are indigent, I just discontinue the MRI. I do clinical evaluations, then I just empirically offer the treatment.
Because a lot of times the treatments that we do are both therapeutic and diagnostic.
Exactly.
So that makes perfect sense to me as well. We do that a lot here too, where we develop a list of things that could be causing the symptoms the patient presents with.
Okay.
And the other thing to note is that a lot of places think of back pain as all the same.
Yeah.
Like every back pain is the same.
Yeah. Yeah.
And it's not. The back is actually quite complex. There's just so many bits and pieces to it that it's not always straightforward to say, well, you've got back pain, so everybody who has back pain gets treated the same.
Yeah.
What we do is we try to get a list of things that could be causing that back pain, and then work through those lists with some of the injections, because those injections are just as diagnostic if used properly as they are therapeutic.
Yeah.
And I take it you have that similar experience.
Oh, absolutely.
Yeah.
Absolutely. That's what we do there too. Then another interesting thing that we do, I noticed that most women, they do have pain from the sacroiliac joints.
Yeah, I agree.
So,
and it's interesting. It does tend to be more common in women.
okay.
And what we're talking about is this area here, the sacroiliac joint. Now, this sacrum is not complete because it's been removed to show the nerve roots, but this joint right here, I'm not getting my fingers out of the way, this joint right here is the sacroiliac joint. You have it on both sides. You can see a little gap there too. That's the sacroiliac joint. And just to give you context, I'm going to show you my butt, but don't be staring at my butt. That area is in this area right here. That's where the sacroiliac lives. It's the connection between the sacrum, which is this triangular bone, and the ilium, which is your pelvic crest. You can, if you put your hands here, you can feel the pelvic crest, and that's a really, really important joint. Why do you think women see it more than men?
Well, I think it has to do with the physiologic functions. The stress of pregnancy and the hormones.
Yeah.
So it tends to have a kind of the pressure effect as well as the relaxation effect of the hormones.
Yeah.
So that makes the joint maybe more lax or so. So that can provoke some pain.
I agree. There was an interesting study I read where they looked at young female athletes, and because of the menstrual cycle, there are periods during which there's a higher level of estrogen in the body. And they find that during those periods, these young female athletes have higher rates of tendon and ligament injuries.
Wow.
So there's a big influence of hormones on ligaments and tendons, which, in my opinion, the sacroiliac joint, it's not as much of an arthritis as it is a problem with the ligaments becoming loose, and it's the ligaments that are more painful than the joint itself is.
Wow.
I don't know if you've had similar experience with that or not.
Sure. Yeah. And like that one, I've actually done a couple of injections. That is intra-articular or peri-articular, injections.
Yeah.
With good results.
Yeah. So the difference between what he's talking about, peri-articular versus intra-articular. Traditional intra-articular means inside the joint. Peri-articular means around the joint.
Yeah.
And the traditional teaching has always been intra-articular, has been put medicine inside the joint. But it's interesting, you've had similar experience as I have, and we didn't coordinate this either, but it sounds like you do a lot of peri-articular. I find the structures outside of the joint to be more commonly the cause of pain than the structures inside the joint. So I agree, the peri-articular seems to be more effective for sacroiliac joints. I'm curious, what are some of the population differences? We were talking about this a little earlier before we started the show, the population differences between Nigerians and Americans, just on average. I mean, we don't want to, this isn't stereotyping, this is just seeing what are kind of some of the differences that you've noticed.
Yeah, well, back home, I discovered that more females, come down with chronic, back pain than, males counterpart. And of course, maybe because of the diet, you know, there's this saying we say in Africa, obesity is a problem of the, you know, the affluence in Nigeria.
That makes sense.
So if you are big, they believe that you are very, very rich.
Rich.
So
That's
if you are
interesting.
skinny, no, you come from a very poor background. So that is the thing over there. So, and interestingly, the problems, you know, the poor people, they don't, you know, they are small size, and they are even more healthier than even the rich guys people that are very, very big.
Isn't that interesting?
So it is interesting.
So there's a correlation between weight and pain, and I mean you can kind of extrapolate that if you have a heavier body, you have more stress on structures, and so weight does cause pain. But there's also other causes that weight contributes to pain issues. So for instance, your fat is actually an endocrine function, or an endocrine organ, meaning endocrine is structures that produce hormones. And so fat in and of itself produces hormones that can cause, just like how the menstrual cycle causes people to be more prone to injury during certain stages, having higher levels of fat can also do that. And so interestingly, in Nigeria, the affluent are maybe less healthy in some ways than the poor. So I take it you tend to see more obese people who may be wealthier but have more pain problems.
Exactly.
That's interesting.
So, but on the, you know, comparatively, we don't have, you know, have them that big.
Right.
So.
I mean, you know, in all fairness, obesity in the U.S. is a bigger problem. And not just in total number of people who have obesity, but also in the amount of weight, or how obese people are. We definitely tend to be up there. But you're right, it tends to be a problem related to the wealth of a nation or the abundance of a nation. However, there's some thinking that it's not as much the abundance of wealth as it is the cultural appreciation of good nutrition, because you can be obese and be malnourished if you're not getting proper nutrition. So imagine there's some of that as well. You were talking about earlier about the tendency that you see in your population is more disc-related issues. Is that correct? And I was curious as to why that was the case.
I think it's related to the physical activities. Those are the things that they are, you know, they do it on manner, you know. People are farmers.
So manual labor.
And all that. So they tend to have these problems. And, you know, even the water fetching, people fetch water, they have to trek distances to fetch water.
Wow. We take so many things for granted that, you know, you turn on the faucet and you have water, but there are still places in the world where you actually have to go somewhere to get water for use. You know, it's interesting because there's this dichotomy where physical labor, manual labor can increase the risk of having back problems, but inactivity also increases the risk of having back problems.
Balance, sort of.
It's a balance, and I find that if you're going to err on one side, it's better to err on the side of having too much physical activity than not. But I know what I'm finding, and this is a conversation I've had with some of my physical therapy colleagues, is that how we're taught to lift things is really important. Like, you know, we always talk about lift at the knees or bend at the knees, don't bend at the waist. But those are really secondary problems. I find that the problem with a lot of manual labor is that they don't know how to load the muscles of the spine to take the weight off of the disc. And that's not intuitive. That's something that we have to learn as physicians, first of all, from our physical therapy colleagues, but then also teach our patient population as well.
I agree with you. agree with you.
So I've been working a lot about trying to understand how the back muscles work, and it's interesting. Like if you look at the spine, and I think I've talked about this to the audience before, it kind of looks like a suspension bridge where these are the muscles that line the spine, but that all of the weight when you're standing up is felt at the joint level, which is back here, and the disc level, which is up here. And so if you're loading the muscles of the back properly, you're essentially taking weight away from the spine and you're pulling it back and putting it onto the iliac crest, which then distributes the weight to your legs and down, as opposed to trying to hold things up with the spine. And normally the evolution of back pain that I see is that people either don't coordinate these muscles well to take the pressure off of the disc and the joints, or that they have an injury causing a tear in one of the ligaments that supports the spine. And so now the muscles don't have leverage off of the hard structures, and it causes a domino effect, which ultimately causes the disc to break down and the joints to become arthritic. And that's how things start. So if we do nothing other than just get people universally across the nation to load the spine better, or know how to contract the muscles, because sometimes it's not intuitive to know what muscles to activate in what situations. And that's where I think a lot of the changes that need to take place in medicine need to start, is understanding how the back loads, how the back distributes loads to protect it from injury. We see a lot of degenerative disc disease, or that label of degenerative disc disease. I like to call that degenerative wrinkles disease. Because it's degenerative discs is something like wrinkles. It's something that happens to all of us. But what we need to be attentive of is, why is one disc aging at a faster rate than other discs?
That's true.
And that oftentimes is from either a loading problem from the muscles, a lack of muscle coordination, or a problem with the ligaments that's not creating enough stability in the spine. Yeah, at least that's been our experience.
That's good.
Yeah. Tell me about some of the other differences that you see. So it sounds like you see a lot of disc issues, a lot of sacroiliac problems, and your population tends to be more women than men. Is that correct?
That's correct.
Yeah. And how about your outcomes? Like when you do these treatments, are these patients that you're seeing routinely, or are you treating and they get better and they don't come back and see you?
Chronic back pain is more or less like chronic diseases that some of them they do have a common frequent basis, but I think in a few of them I've not seen them. Maybe after one or two interventions they are gone.
Yeah.
So, and what I think happened was, once you're able to break the cycles, and I think they are good. So
I think a lot of times we just need to temporize until the body can heal itself. But I think while you're here, I'm going to show you some of the things that I've done, or some of the things that I've figured out, where we can facilitate or even edge on or increase the rate of healing in the body, instead of just temporizing the symptoms. Because my goal is to change how pain management is done, so that we're not just temporizing, we're not just numbing problems and waiting for the body to heal, but we're actually starting to understand the dynamics of why that pain started, and how we can facilitate the body to fix itself, and move things along. Because I think there's a lot more patients we can actually treat, and then we never see them again, than what currently is standard of care. But hopefully you'll help me take that message back to Nigeria as well.
Absolutely. That's an interesting message, and I like that too.
Yeah.
I like that.
Well, we're just about out of time. Normally I like to give an opportunity for the audience to ask any questions, so we'll just chit chat a little bit to see if anybody has any questions for Dr. Suleiman. about his experience working in Nigeria, about his experience coming in and observing us. But today is just your first day, and I appreciate you staying up for this, because right now it's what time is it in Nigeria?
Now this is
You're about 7 hours ahead, is that right?
7 hours ahead of this.
So it would probably be 1 or 2 in the morning for you right now, correct?
Sure.
What time do you usually go to bed?
Oh, naturally by 12.
12. Okay, all right. So we're pushing the margin a little bit, but not too bad.
Yeah.
But you have to be exhausted. He just flew in. How many hours?
16 hours.
16 hours on one flight.
Yeah.
Just one flight was 16 hours.
Yeah.
So definitely appreciate you staying up for
My pleasure.
for the show.
Thank you very much.
If anybody does have any other questions, feel free to send us a message on Facebook or send us a text. And please ask questions. We love to have clinicians visit and have this exchange of ideas, because there's stuff that I learned from you, and I hope that you learn from me.
Sure.
And it's this process by which we can start evolving the science, so that we're not the last resort. We're not the place to go where you just want to get comfort. We're actually the starting point where you want to go to get fixed.
Absolutely, I agree with that.
All right. Well, thank you again. It's great talking with you. And thank you to the audience for paying in. And we'll have our next show in a couple of weeks. Look forward to seeing you.